My name's Tom Murray. I'm a pharmacist. I'm also an attorney.
Now, that's interesting.
And so I can fill your prescription or write your will. I just hope I don't have to do that on the same day. I grew up in Arkansas. That's where I went to pharmacy school. My wife got a job with a CRO in the Research Triangle Park, and so that's how we ended up a clinical research organization. It's kind of a pretty big business segment there in North Carolina, along with several biosciences organizations. But I represented a part of North Carolina where the Research Triangle Park is, and so my district bumps up against the Research Triangle Park. So a lot of my employees, a lot of the constituents in my district are employees of biosciences organizations that live and work in and around the Research Triangle Park in North Carolina. So that's just kind of where I come from. I also have about 4 times the average Asian Indians in my legislative district compared to other legislative districts, and so one of the highest per capita PhDs. So I've got diabetes impacts my district based simply on the demographics, Asian Indians, and the people working on diabetes in bioscience research. So that's kind of part of my interest in this, as well as I treat diabetes every day as a pharmacist, help patients navigate complex drug therapy to make sure that they maximize their care. We have a joint legislative task force on diabetes prevention and awareness. House Joint Resolution 647 was passed last year, creating this joint legislative task force, and the purpose of this task force is to study issues relating to diabetes from soup to nuts, from prevention to treatment, and to hopefully have some measurable changes as a result of the task force. This task force was recommended from North Carolina has a Diabetes Advisory Council. This is one of the legislative items that this Diabetes Advisory Council, which has a significant amount of people. I mean, it's a 40, 50 member advisory council with a lot of folks from pharmaceutical manufacturers down to providers and patient advocacy groups as well. And one of the legislative recommendations was the formation of a legislative committee focused on diabetes. This is straight from the legislation, so this is, if you look up House Joint Resolution 647 on the North Carolina Legislature's website, this is straight out of the legislation on different things. As you can see, awareness and need of certified diabetes educators, that was something that Representative Trine referred to as well. Promoting education, public awareness. Those are the kind of things that we've been working on so far. We've met 3 times thus far. I am co-chair. There's a senator who's co-chair with me as well. We've had to get some folks up to speed. We've got legislators on this committee that don't know anything about anything except lawyers. They're lawyers, so they don't know what's your utility. Why are you here? So we have to. This is what a pancreas is. Very similar to what the good doctor talked about this morning. We've had that lecture from an endocrinologist with UNC Healthcare. Okay, so we kind of got to start at the beginning. And so why do you need to why are we paying in Medicaid for somebody to test their blood sugar 4 times? Couldn't we just do it twice? That kind of conversation needs to be had if you don't know why you're checking your blood sugar. If the legislator doesn't understand that, that's kind of where we had to start. And so if you only remember one thing from my particular presentation, this is the report that the task force came up with after our first 3 meetings. And so within that report, you've got a copy of the legislation that North Carolina passed creating the task force. We also have a copy of the legislation passed in Kentucky that I will refer to, and I know Stuart's going to refer to as well, that will help save your state money on how you treat diabetes. And so that should all be of interest to everyone in this room, the Kentucky bill that was passed. And so if you just remember one thing, go look up that report, and that's the easiest way to find it. So here are some of the findings that we've had. You've seen all the numbers. These numbers were addressed. I think that should be a B. So, and so, not a cheap disease to treat. Not a cheap disease to treat. Specific to North Carolina, about 1.27 million North Carolinians. We got about 9 million people in our state, so good chunk of folks. 13th in the highest, and 10 billion cost 18 billion in 2025. So this is a significant disease from a cost perspective in North Carolina. We have 5 recommendations. After our first 3 meetings and our first report, we have 5 recommendations. We have a diabetes prevention and control branch within our Health and Human Services Department. We want them to continue to do their good job about educating the public. We also, there isn't really a standard out there in the marketplace, clinical guidelines to help start testing patients that have the risk factors for diabetes. So where do we start? You know, if you've got, how many risk factors have to be present before you start watching them? That doesn't exist, and so it's got, so if you don't measure it, you can't improve it. And so when do we start measuring it? And so we think that this is a good way to start this prevention cycle instead of the treatment cycle. Prevention could be key if we start testing folks early enough, if we know they have a certain number of risk factors. We already do this kind of stuff for CHF, for congestive heart, for if you're at risk for cardiovascular disease, if you got a mom and dad have a heart attack, mom under 55, dad under 45, they had their first heart attack, you're overweight, you smoke, cholesterol, this, that, and the other, you start getting into a cycle, and you're going to get treated. You're going to have numbers. You're going to start having numbers as part of good clinical best practices. This doesn't really exist in diabetes, and so that's kind of one of our recommendations. We have a diabetes advisory council. It's large and unwieldy, and that can be good to get everybody around the table. But if you have so many people, you can't ever get them around the table. So that was one of the issues that we've dealt with the Diabetes Advisory Council, and so we want to support their work, make them as most efficient as possible, and that might actually end up being paring down this group so it can get more manageable and have people who can actually get together instead of having 40 people and have 25 people show up at every time when you're always missing 15 people. And so that's kind of one of the just boots on the ground type issues that we've had to deal with. Interagency and intra-agency communication for efficient use of states funds. That's basically what Kentucky Senate Bill 63 was about. I expect this bill will be introduced in North Carolina, and we have long sessions on odd number years. We're in a short session right now. It just started Wednesday. No recorded votes yesterday, so that's why I was on a plane all day. So, and I made sure the speaker gave me a pass. So no recorded votes yesterday. So, but Kentucky Senate Bill 63 will be something that we will definitely be doing and looking at and implementing in North Carolina. I would suggest everyone get a chance to look at that bill and listen to what Stuart has to say about the experience in Kentucky getting that bill passed. All right, this is a personal one for me. So, test strips. In North Carolina, we have a single source provider. Now, so what I mean by that is all of our Medicaid patients can get one diabetes test strip and one machine. So it's only one select provider for all Medicaid patients. Okay. Generally, when you do that, you get a good deal, and that's why we did it. And it was done a couple years ago. They switched providers in March. Okay, so they bid it out and decided we're no longer going to have our diabetes patients on this particular diabetes testing machine and test strips. They're all going to get switched over to this one now. Okay, that's not easy. That's not easy to do. And so the recommendation is that if you're going to do that again, you might want to think about the disruption of care, and now I've got to re-educate all these patients on a brand new machine and brand new test strips, and you got to throw away all the old machines and give them brand new ones. So I asked a question to our department. I said, so if a newly diagnosed patient on November of 2011 gets a new machine and new test strips, we changed providers on January 1st, and so they go in for their refill or get however they get their diabetes test strips, they have to get a brand new machine and a brand new box of test strips that they've never used before. And so there's kind of some waste in there, and just in the process of getting that done. So I kind of wanted to make sure the department factored that in. It's not just a dollars and cents thing. Well, we can get more rebates from this manufacturer than this manufacturer and get a better deal. There is a undercurrent cost of training all those patients all over again and throwing away all those machines. So that needs to be factored in. And so additionally, this particular provider has a box of testers. So this is a provider that has a box of test strips, and it says for Medicare and Medicaid use only. And then there's a box of test strips that doesn't say that. The Medicare and Medicaid use only box of test strips costs $30 at wholesale, less than the other box. Okay, now guess which one providers have to bill Medicaid for? It's the more expensive one, and the rebates are based on that. And there's just something odd about that to me, and so I wanted to highlight that through this committee and let the department understand that there are ways to manage costs that might not involve the rebate process for pharmaceutical manufacturers. There might be lower cost options out there. So I wanted to interject that as part of a boots on the ground, getting in the weeds type policy, that this is why you need healthcare providers working in the legislature. And so this is a very specific example of a way that we can actually save real money and prevent disruption of patient care. And if you didn't know anything about any of that, then how could you ever affect that kind of policy? The other thing I'll say is why should we be interested in diabetes? And the endpoint, the logical endpoint of untreated diabetes is blindness and amputation. We have a category of patients in Medicaid called aged, blind, and disabled. Well, there's two of them right there. You got B and D because of untreated diabetes. And I don't care how deep the Medicaid cuts get from Washington, we're always going to take care of blind and disabled folks. I mean, that's going to be the baseline. The baseline care of Medicaid will be blind and disabled. We will get there if we're not careful with how we treat diabetes and have more folks on those roles. So it's a pay me now, pay me later type scenario. My dad's mom, my paternal grandmother, was a type 1 diabetic. She died at age 65 in the mid-'80s. She tested her blood sugar through her urine. And this is when I was about 10 years old. We've come a long way in the treatment of diabetes. We've also come a long way as a country on the number of people with diabetes, and I think that's contributed to our progression on how we treat it. But it's amazing to me, just in my short life, I have not been in the legislature 20 years, how much diabetes treatment has changed, and we need to reflect that in our policies. And one of my favorite quotes is as a healthcare provider is, law should not dictate practice. And so that's kind of where we're at. As law is dictating practice, like there's providers that are able and available in the community to do things for patients if we will let it happen. And it can't be about silos. It can't be about turf. It's got to be about patient outcomes. And one of the things we've done in North Carolina is basically started our own homegrown grown accountable care organization, ACO. It's called Community Care of North Carolina. It's for Medicaid. It's focused on the most expensive Medicaid patients, and we have boards of directors with every discipline sitting around the table coming up with care plans for patients, and it has kept North Carolina Medicaid costs flat over the past decade to the tune of about $1 billion in savings. Now, if you're interested in that, I can show you how we did it in North Carolina, but that's the where we need to go. We can't continue to have silos and fee-for-service and all this stuff that's going to bankrupt our country. We've got to start paying people for actually making sure that our patients are getting better. Last thing I'll say is, my first week on the job in the legislature, I asked the question, how many patients do we have in Medicaid that have diabetes? How many of them are at goal? How much would it cost us to get the patients who aren't at goal to goal, and how much would it save us if we did? Okay, so that was about 14, 15 months ago, and I still haven't got an answer to that. That's a big problem. That's a big problem. If you don't measure it, you can't improve it. And we don't even know where our patients are in the treatment continuum. And we're spending billions of dollars to manage these patients and pay for all these things, and we don't even know where we are on the road. And that's a big problem. So that's the last thing I'll say. So I'll turn it over to Stuart